Good afternoon. It's a pleasure to be with you. I've been asked to discuss the year in thyroid. Here are my disclosures. And these talks are always a bit of a challenge to put together. I've restricted the papers I'm going to discuss to those that were published between January of 2025 and February of 2026. I've restricted this to clinical studies, and I've picked some papers that I think were interesting over the last year, but I would note that this is obviously highly subjective. These are my personal favorites, but apologize in advance if I missed your own study or some of the ones that you like the best. I've divided this roughly into cancer and nodules, hyper and hypothyroidism, and pregnancy. And to start with, I won't discuss this paper, but I can't not note that probably the paper published in the last year that is going to do the most to change clinical practice is the updated American Thyroid Association Cancer Guideline, and this will be discussed separately during the course of this meeting. So jumping into the papers I've selected, the first one I want to note is this one. This is a retrospective cohort analysis from the Mayo Clinic, where they used artificial intelligence to review medical records of about 11,000 adults who underwent an initial thyroid ultrasound over the interval between 2017 and 2021. They excluded people with sort of a clear reason for having a thyroid ultrasound and no nodule or cancer or surgery. And what they were trying to get at was whether the reasons that people were having these thyroid ultrasounds were actually appropriate. And in this analysis, they found that most were actually, but about 1 in 13 ultrasound orders were for unclear or inappropriate indications. And these inappropriate indications were more common in younger patients, those with thyroid dysfunction, those seen remotely, not in person, and I'm happy to say by non-endocrinologists. So the endocrinologists maybe are doing better. But this does highlight sort of the ongoing need to try and optimize strategies for who's getting thyroid ultrasound. And that matters because of this paper, which is looking at thyroid cancer overdiagnosis. We all know that this has been a major issue in the US, but also globally, probably over the last few decades. This study from JAMA Network Open tried to model, based on US data, what proportion of papillary thyroid cancers diagnosed in the US between 1991 and 2019 were likely overdiagnosed, meaning those that in this modeling were patients who would have been destined to die from unrelated causes before they would die of their papillary thyroid cancers. And based on this analysis, they suggested that somewhere between 72 and 94% of these papillary thyroid cancers were probably overdiagnosed. Again, probably not a surprise in light of prior data. Authors suggested that if ultrasound for non-palpable nodules was reduced by about a third, that would reduce the diagnosis of papillary cancers by 41%. And if it were reduced by two-thirds, which is probably not an achievable objective, it would reduce the thyroid cancer incidence by 41%. These are all papillary thyroid cancers. The cost of doing that, they said, would actually be relatively low, with a mortality increase of less than 0.1%. So I'm not sure what the right number of ultrasounds to do is, but this pair of studies does suggest that perhaps we need to think carefully before we order this to try and avoid additional overdiagnosis of small and not clinically meaningful thyroid cancers. Shifting gears to nodules, this is just a fairly preliminary study published in Thyroid last year, but it's somewhat novel. It's looking at a new ablative technique for benign thyroid nodules. So this is a non-thermal technique that applies nanosecond pulsed field ablation. So tiny, tiny duration electric pulses, which apparently will initiate the endogenous apoptosis pathway. So the advantage of this potentially would be that perhaps less risk of damage to adjacent structures when you're not using a thermal technology for the ablation. And this is a small sample size, sort of a preliminary study with just 30 patients. But I will say that the published results for this 30 patients suggest really nice volume reduction within the first 13 months of treatment. So stay tuned. Maybe this is something that we'll have in our armamentarium going forward. I want to shift gears now and talk about a paper that's looking at associations between use of the GLP-1 receptor agonist medications and risk for thyroid cancer. So in the US, although not necessarily everywhere else around the globe, all of the GLP-1 drugs have on the package inserts a black box warning about potential risk for medullary thyroid cancer based on preclinical studies in rats and mice. And there have been quite a lot of papers over the last 2 or 3 years that have been trying to establish whether there truly is an association between any thyroid cancers and use of these drugs or not. I'm highlighting this paper because it's the largest study to date. So this was an active comparator new user cohort study. These are identified patients from electronic health records from the US, 6 national level, and 4 more local health system records. And they took these records from 460,000 patients who were initially treated with GLP-1s and compared them to patients who were initiated instead on other diabetes medications, so SGLT2 inhibitors, DPP4 inhibitors, or sulfonylureas. And they looked to see whether there were differences in rates of diagnosed thyroid cancer in these groups of patients treated with the different diabetes medications. They did a number of analyses to try and adjust for confounding using propensity scores, and they saw no difference in thyroid cancer rates in the GLP-1 users compared to the users of the other medications. And these results were robust when adjusted for confounding using different measures. So I think a fairly reassuring, very large data set. And then another paper, much smaller paper, but looking at the same question in a different way. So these are data from Memorial Sloan Kettering that were recently e-published. They looked at 536 patients with known differentiated thyroid cancer and relatively high-risk thyroid cancer. So 58% of them were intermediate to high risk. And they matched those patients on GLP-1s 1-to-1 to patients who had also differentiated thyroid cancer but had no GLP-1 exposure. They were matched based on the date of cancer diagnosis, tumor staging, body mass index, and presence or absence of diabetes. And I think very reassuringly in this small data set, there was no association of GLP-1 use with thyroid cancer recurrence or persistence in any of the ATA risk categories. So another reassuring study, but I think longer follow-up, larger data will continue to be needed. Shifting gears now to thinking about right-sizing treatment for thyroid cancers. So the new ATA guideline really suggests not overtreating when we don't need to overtreat, that there's morbidity associated with that. This is a retrospective cohort study from Ito Hospital in Tokyo, looking at 401 patients who underwent surgeries for papillary thyroid cancer between 2005 and 2012. They were all intermediate risk patients, so N1B, lateral node metastases. They all underwent total thyroid, half of them roughly underwent total thyroidectomy, half of them roughly underwent lobectomy, and outcomes with regard to overall survival and recurrence-free survival were the same. So no benefit in this retrospective analysis of total versus lobectomy in this intermediate risk cancer group. Another paper kind of looking at trying to right-size treatment for low-risk cancers here. So this is a prospective cohort of patients undergoing active surveillance. 200 patients followed up for a median duration of 71 months, and they looked at basically who dropped out of the active surveillance category for their small low-risk papillary cancers and opted to transition to thyroid surgery. And that crossover rate overall was about a quarter of the patients, about 24%. So 37 patients in this cohort, most of them wound up shifting to a surgical approach because of documented disease progression. So that was 21 of them, 15 just because of patient preference, and a single patient because they couldn't tell with ultrasound didn't have a good sense of whether there was progression or not, I guess. What they found also that is consistent with prior studies is that older individuals were more likely to be able to sort of remain in this active surveillance category rather than shifting to surgery compared to the younger individuals. Another paper, again, kind of looking at right sizing our treatment. This is the follow-up to a randomized trial that was published in the New England Journal in 2022, here with a longer duration of follow-up for out to 5 years. So this was a randomized trial of patients with low-risk differentiated thyroid cancer, and they were randomized to radioactive iodine following thyroidectomy versus no radioactive iodine. And I think reassuringly in this study, there was no difference in therapy. So continuing to see that in these low risk patients, probably no benefit of radioactive iodine treatment after surgery. Another study looking at the same question is this one from the UK, published in Lancet last year. This was a randomized trial, multi-center, non-inferiority trial that randomized 500 participants either to have radioactive iodine versus no radioactive iodine after total thyroidectomy. And this was sort of a broader group of thyroid cancer patients by staging. So they could be stage P1, 2, or 3, or T3A with central node disease. Primary endpoint here was 5-year recurrence-free survival. They saw no difference. So again, more data perhaps that we really should not be overusing radioactive iodine in our lower risk, or maybe here even into some perhaps intermediate risk patients. Here's a paper looking at TSH targets in patients with differentiated thyroid cancer. So this is a retrospective cohort where they looked at thyroid cancer patients followed for 14 years, and they looked to see the associations between serum TSH levels and likelihood of recurrence rate for thyroid cancer. And what they found, I think reassuringly, was that there was no difference in risk for recurrence when the TSH was in the bottom half of the reference range, 0.5 to 2, which is what the old ATA guideline recommended, for all of our patients, compared to patients with a TSH in the upper half of the reference range, 2 to 4. So I think this reassures us that the recommendations and the new guideline, that it's fine to keep the TSH in the reference range in our differentiated thyroid cancer patients who are not high risk, is a safe approach. But they did note in this study that there was increased risk with a TSH greater than 4, and that risk was cumulative. So the longer that the patient had an above normal TSH, the higher the recurrence risk. So this suggests that within the reference range is probably optimal for most of our thyroid cancer patients, but above it still is not. I'm going to shift gears here. This is a medullary cancer study that I think is just clinically useful. So this was published in 2025 in JAMA Head and Neck Surgery. 509 patients in a retrospective analysis. These were all medullary thyroid cancer patients, and they were divided into groups based on metastases. So one group had no lymph node metastases, one had just central nodes, one lateral nodes, and then the last group had upper mediastinal nodes. And they looked at whether the preoperative baseline calcitonin could predict which group patients would fall into. And it actually sorted patients pretty well. So they were able to provide some thresholds here for preoperative calcitonin levels that will predict kind of extent of disease that is uncovered at surgery. And I think these numbers are going to be helpful going forward for preoperative surgery planning. One last thyroid cancer patient is this one. So this is an anaplastic cancer study. This comes from the MD Anderson Cancer Center. And this was intended to be a randomized trial, but they had trouble accruing. So they wound up kind of combining data from the trial that didn't come to completion with just prospective cohort data. And what they looked at were patients who had multimodal therapy for stage 4B anaplastic thyroid cancer. So that multimodal therapy meaning surgery if indicated, radiation if indicated, sort of chemotherapy. And then they added on in some of these patients pembrolizumab as adjuvant therapy. Follow-up that was published here went out to 2 years, and what they found in this fairly small study was that at 12 months, the patients who did not get the pembro had a survival of 80%, and at 24 months, that was 52%. But somewhat remarkably, all of the patients who received the pembrolizumab were alive at both 1 and 2 years. So this is small, this is not really a fully randomized trial, but I think it provides some preliminary data suggesting that pembro may be an effective strategy to prevent recurrence and prolonged survival in this group of 4B anaplastic thyroid cancer patients. So jumping to hyperthyroidism, this is a study that got some attention, published in JCE&M last summer. This was a small randomized trial in which patients with newly diagnosed Graves' disease, so treatment naive, were randomized either to sort of typical treatment with methimazole or that treatment with methimazole and the addition of a 10 milligram weekly dose of methotrexate. They saw no difference in thyroid hormone levels in the patients in the two groups, but the patients treated with the methotrexate by 9 months were starting to have lower TSH receptor antibody titers, and the group treated with the methotrexate in addition to methimazole by 15 and 18 months were more likely to be able to come off the anti-thyroid drug. So this is a small trial. I think it needs confirmation, but I think it's potentially a useful modality. Important to note that at this low dose, methotrexate was not associated with side effects in this trial. Here's a paper that is a target trial emulation. So it is not a randomized trial. This is a study that is using data from observational data sets and doing some statistical manipulation to try and kind of understand what a trial might look like, what the results of a trial might look like. So again, it's kind of a quasi-experimental study design. And here they looked at patients with thyroid eye disease who were treated across 80 US centers, either with teprotumumab, with glucocorticoids, or with conservative treatment, so neither of the above. They tried to match for baseline covariates based on propensity scoring, although, of course, there is, in this kind of analysis, certainly the potential for some residual confounding. And they compared treatments for these different modalities for thyroid eye disease and found that treatment with the teprotumumab was actually associated with reduced risk of death, cardiovascular, renal, and infectious outcomes, counterbalanced by a higher risk of hearing loss with the teprotumumab. So this is not really a randomized clinical trial. I don't think we can definitively conclude that this outcome is right, but it's interesting. And I think it will be interesting to see going forward whether some of the newer, more targeted drugs for Graves' disease that are going to be coming online over the next few years also potentially are associated with reduced risks for mortality and other outcomes outside of the actual eye disease or thyroid disease outcomes. Another trial, here this is a trial, looking at thyroid eye disease. We all know there was a New England Journal trial published a number of years ago from Europe demonstrating that treatment with selenium was beneficial in patients with mild to moderate Graves' eye disease. Now, I practice in the United States where selenium deficiency is not a problem, unlike Europe. And I have never really known whether in a setting that is selenium sufficient, such as my own, this would be a useful measure. So conveniently, now we have a trial that's looked at that. This was done in Korea, where selenium in the diet is adequate. They randomized patients to selenium versus no selenium if they had really mild to moderate Graves' ophthalmopathy, and they saw no difference in outcome. So I think this suggests that the benefit of this therapy probably is very context specific. Moving on to hypothyroidism now. This is another one of these emulated target trials. This one emulating a trial that I think a lot of us would love to see done in reality. So looking at the effects of levothyroxine therapy in older adults age over 50 with subclinical hypothyroidism, here baseline TSH of 4 to 10, compared to patients who don't get treated. They included 22,000 patients in a UK population, and of those patients who were median age 66, 62% had received levothyroxine. So again, some statistical manipulation trying to adjust through probability weighting for potential covariates, including age, sex, body mass index, the presence of comorbidities, lipid levels, hypertension, baseline TSH, use of hormonal medications, and smoking. And in this analysis, they found that the levothyroxine actually was associated with decreased cardiovascular mortality and all-cause mortality, and they did not see adverse effects on bone. Now, important to note, of course, this really isn't a trial. This is an emulated trial. It would be nicer to have a trial. But I think it does suggest perhaps that there's a treatment benefit for cardiovascular mortality in these patients. We know from trials that there probably isn't a symptomatic benefit in this patient population. But also important to note in this analysis that the cardiovascular benefits were only in those patients with TSH above the age-specific reference range. So that is really a higher TSH in older individuals. And after at least 5 years of treatment, you're not going to see an immediate benefit. Another paper looking at management of our patients with hypothyroidism is this one. So this looked retrospectively at about 50,000 consecutively diagnosed patients with hypothyroidism and compared them to 393,000 untreated euthyroid individuals over 14 years. And they looked at thyroid function tests in the treated versus untreated patients and saw that they were different, as you might expect. I think that's not a surprise to anybody who treats patients with hypothyroidism. So both the TSH and the free T4 levels tended to be higher in the patients on levothyroxine than in the euthyroid patients who were not treated with levothyroxine. And the differences in those thyroid function tests increased with the increases in levothyroxine dosing. It was also, I think, notable in this study that of these 47,000, almost 48,000 patients with hypothyroidism who were on levothyroxine in a real world setting, only 43.8% actually had TSH levels in the reference range. So suggesting that all of us kind of collectively are doing a fairly poor job at targeting therapy and really getting patients well controlled if they have hypothyroidism. And this study suggests that that may truly matter. So this is a retrospective cohort of 41,000 adults who all initiated levothyroxine between 2004 and 2017. And this looked at the effects of under or over replacement, so TSH either lower or higher than the reference range, on risk for incident heart failure. And what they saw was that both under and over replacement of thyroid hormone was associated with higher heart failure incidence, with cumulative risk over time, meaning sort of the longer that the TSH was outside the reference range, the higher the risk for inducing heart failure. So I think this, together with the prior study, again suggesting that it probably is fairly important to try and get the TSH right. Here's a study that provided one, perhaps a new strategy for how to do that. This was a randomized trial that randomized patients who had hypothyroidism and were on levothyroxine to either do what we typically recommend our patients to do, which is to take their levothyroxine fasting in the morning at least 30 to 60 minutes before breakfast. And the other group, the other strategy here, was patients who were told to take their thyroid hormone with breakfast, but there was an empiric baseline increase of 15% in the levothyroxine dosing to, try and adjust for the presumed decrease in absorption. And what they found in these patients was that the TSH stability really was not different by strategy, that the TSHs remained at goal and in the patients taking their thyroid hormone with breakfast just as well as they did in the fasting group. And so that may be a reasonable strategy and maybe an attractive strategy to patients based on the fact that at the end of this study, almost 90% of the patients chose to continue the non-fasting intake, just more convenient to take this with breakfast. One last study to share with you is this one on pregnancy. This is really to highlight some of the work being done by an international thyroid and pregnancy research consortium. And just by way of transparency, I should note I'm one of many authors in this paper and in this group. So we are pooling data these days from 25 different pregnancy cohorts. This study was published in Lancet Diabetes Endocrine last year, and we included 63,000 participants from across these 25 cohorts, and we're able to do individual participant level meta-analysis looking here at associations between maternal thyroid status and risk for gestational diabetes. And we've done similar analyses looking at other gestational outcomes over the last several years. So, interestingly, in this analysis, there was no association between maternal TSH or maternal thyroid antibody status and risk for gestational diabetes. But compared to euthyroidism, isolated hypothyroxanemia, meaning normal TSH with low free T4, or just a lower free T4 concentration itself, were associated with higher gestational diabetes risk. Now, guidelines currently do not recommend treatment for isolated hypothyroxanemia. So I think this doesn't necessarily influence clinical decision making, but I think it's interesting. And I think it's sort of adding to our body of evidence from observational data sets that it may not just be the TSH that is predictive of risks of adverse thyroid, of, at, of abnormal, sorry, that's what I'm trying to say, thyroid function during gestation. The final paper I'm going to highlight is not even out yet. It is going to be out imminently, though, and so I'm kind of hoping that perhaps for next year, this might be one of the papers of the year. So stay tuned. There's going to be an updated American Thyroid Association thyroid and pregnancy guideline coming out, as I said, very soon. This is going to recommend some shifts in how we think, especially about subclinical hypothyroidism and thyroid autoimmunity and the gestational and preconception setting. So with that, I'd like to thank you very much for your attention, and I am available for questions by email.